start from that end. Dr. Pietro, you are an emergency care physician with more than 25 years of frontline experience in the emergency wards, seeing patients. So approximately, what would be the percentage of patients who come to the trauma or the emergency who have cancer?
Sorry, can you repeat? What would be
The approximate percentage of the patients.
We see a lot of presentations. So going from an incidental finding, which is the best case scenario, when we do a scan for other reasons, and incidentally we find cancer at a very early stage. That is almost always good news. So
I agree.
we like to break the news to the patient and immediately present the bright side. This is good news because you can treat it. You have options. You can do something about it. But we also see the other end of the spectrum, people that know that they have cancer and they are suffering with complications of treatment or complications from the disease. And very often we also see patients that have symptoms, and we are the first ones to diagnose very advanced metastatic cancer. And we have to break the news and start negotiating a treatment plan.
Okay. I'll just quickly follow it up with a sub-question. The next question would be, has it been challenging to discuss these difficult conversations in that space? So do you feel a specialized room or an area should be available?
I wish we had that. Sadly, the reality in the emergency rooms of most hospitals, there's no space. There's no space to have private discussions. Very often we have to have those conversations in the best place we have available at that moment. And sometimes, sadly, it's in front of other people without much privacy, without the calmness, the quiet, the silence that these kind of conversations would require in an ideal world. And on top of that, most of us were never trained when we went to medical school. We had to learn it on the job, develop our own sensitivity, our own way to approach it and find out what works, what people want to hear. For example, one thing that I learned very quickly is not to kill hope.
Yes.
When you disclose a cancer diagnosis, there's always something that you can offer, whether it is about further testing, further input from other specialists, treating the symptoms, making sure that the person doesn't feel alone, that they feel supported, that there's going to be a follow-up. You're not going to give them bad news and leave it there.
Yeah, that's wonderful to know. Dr. Rene Anand, so you're a neuroscientist, undergraduate from IIT Madras, one of the most premier institutes in the country of India. And what has led to your journey in founding your company, NeuroXTEM? And how do you think NeuroXTEM is going to pave way for the therapies in cancer or curing cancer?
That's a wonderful question. As you know, that I gave a keynote talk yesterday where we are able to make human models of the brain. And one of the ones we made is of brain cancer. Now we can see the blueprint of cancer, and it is becoming apparent. We are daredevils, by the way. As you can see, our history is always do what everybody says impossible. One of the impossible things we are setting up to do is to reverse stage 4 cancer, metastatic cancer. And everybody I've ever talked to in the world of oncology says it's impossible. We're going to do it. Now, I want to say what motivates me. A few months ago, I lost one of our greatest friends, long-term neighbors, to pancreatic cancer. it happened within just 3 months. And it was the saddest last week to sit down there and talk to him, because he always talked about our technology and all the things he could do, but you felt completely helpless as you watched him slowly pass away. He's very stoic about it. We chatted about his journey in life and things, and that's the real topic of today.
Yeah.
That we are all humans, and we have to be there in the moment with your friends and family. I'm not a physician, so I don't see this on a daily basis. So when I do see it, it's pretty awakening, and you'll see it amongst your parents and your children and things. And so it brought about an even greater determination to take risk. I'm not reckless, but we'll take the risk and we'll make it happen. I promise you, in 5 years it'll be done. Hold me to that promise.
Yep. So any other experiences that you would like to share, Dr. Rene, regarding your working with mentors or working with other physicians who had to deal with cancer patients?
Actually, I had a great mentor. It wasn't necessarily in cancer. His name was Dr. J. Rao, and he was in Parkinson's. A lovely gentleman, old school, and he taught me a lot about the brain anatomy of Parkinson's patients. And he always said, Rene, one day you are the one with the technological changes that'll make what we physicians can do. We're the caregivers of our Parkinson's patients. They slowly pass away. Unfortunately, a couple of years ago, he himself passed away. So I'm left with this heavy responsibility of this long-term relationship, and also being around patients and looking at them. Because I come from the technological world. We don't typically see patients. But he made the opportunity to teach us a greater purpose. Physicians know that intuitively, because they're there every day. They watch life walk away. We don't see that. So when you're given that privilege and the training and the motivation, I feel a compelling sense. And I've said this before, your only wealth is your health. Everything else won't matter when that time comes. So I think the doctors know that, but trust me, most of us in the technological world, we kind of think we live forever and never face these challenges. But it's not true. You will be brought to your knees sooner or later, and it is a delight that I can bring technological power into the field of health with some level of humility.
That's nice to know. So, Stephen Wall. So you're a pharmacist and an entrepreneur from Germany, and you're also heading Vital Wealth Pharmacy Group. So what do you think you will do when you see a cancer patient who's on a stage 3 or stage 4, and he asks you some vital questions about chemotherapy? And how do you think you're going to tackle that mentality of the patient?
That's a good question. It's late when we see the patient with stage 3 or stage 4. Normally we become patients. We have many patients in the pharmacy because we have 2 big oncologic clinics nearby us. And but if they have stage 3 or stage 4, we improve. We try to help them with some other ways also. We don't tell him he should not take the chemotherapy. That's not our work. But normally we make an appointment with the patient, and we get the clinical letters and send them through a specific database, and look what kind of cancer he has, what kind of stem cells there are, what kind of stem cell pathways, and we search some supplements, nutritions, repurposed drugs who can help him. And then we talk to the complementary oncologist, yes. And if the repurposed drug is a prescription drug, then nominally he prescribed it. And what we notice is after the appointment, the patient become more open because he had the chance to gain his control back. And he had a chance, and it, like Dr. Gabelli said, you must give the patients a little bit hope at the end of the appointment, and then you can discuss further with him.
Very true. So I'll just ask another question. What do you think are the barriers? What do you think makes it difficult to open up a communication related to diagnosis of a cancer?
I think it's a difficult situation for the patient. He get his diagnosis, he feel helpless, he feel angry, he feel a little bit lost. And unfortunately, in our healthcare system, due to the time pressure, the patient reduced often to a number. So he don't know about the disease, he don't know about the treatment. And this is the point where we come and where we get the clinical letters, the hospital letters, and look over the database and look if we get the patient to us and talk with him and give him this hope, what he needs. I think cancer is also a psychological problem. Yeah, we all know if I have a positive thinking, then my immune system grows up. Negative thinking, it decreases. And I think it's very, very important that the patient is going out and said, okay, I have a little hope.
Wonderful. So back to Dr. Pietro once again.
Yes, I wanted to add to that. My experience of talking about cancer for the first time with patients. Occasionally, we don't know. We see something that might look like cancer, but we don't have the data yet. We leave the conversation quite open about the fact that we need to do other studies. But occasionally, we just have to disclose the results. And the majority of patients respond with shock to the news. It's like a big emotional shock to the system. And if anybody has ever received other types of bad news, you start feeling dizzy, your ears buzz, you stop listening. Everything that happens afterwards, you will not retain much information about what you hear. So that's when we try not to overload with too much technical information. We concentrate on the caring aspect, how we're going to look after you, when we're going to see you next. We're going to discuss more in the next appointment. You will have a lot of questions. Come prepared, come with someone else, and we'll start from there.
Exactly. That was about to be my next question. So do you have a strategy, or do you have a stepwise approach to reveal the diagnosis that a patient may have? Like, how much of your information would you disclose at a particular time?
I stick to my skill set. My place is doing a diagnosis, but for example, I'm not an expert in then deciding what is the next step. I can organize a biopsy to know what we're dealing with, but then I will need to refer the patient to a multidisciplinary team. So we'll need an oncologist that can weigh the pros and cons of different types of chemotherapy and immunotherapies, a medical oncologist that can weigh the pros and cons of radiotherapy. Very often a palliative care team that will help managing the symptoms while we do all of that.
Wonderful. Also, to follow it up with another question. So right now, we are in an era where there's a lot of fields coming together to have a multidisciplinary approach, right? So at the first go, would you encourage the patients to have a multidisciplinary team approach? Or would it be, again, a step-by-step process?
The reality is that most cancer services are set up by default as a multidisciplinary team. especially in the UK where I practice, all decisions about cancer treatment are nowadays made in agreement, in a meeting, and very often that has its pros and cons. On one side, we feel frustrated because there is no single decision maker that can give us an instant answer. We need to wait for that specific day of the week when the team meets and decides what is the best next step. But on the other side, that helps a lot because in that moment there is a discussion about different options, different steps. There will be someone that might have a second look and say, why don't we take a different course of action before we give treatment? Why don't we do an additional test? So it does have another layer of benefit. And then we have the option of integrative approaches and complementary approaches. It is better if they are part of the team, because, for example, we know that nutrition plays a role, well-being of the mind plays a role. Supplements can play a role, but they can also interact negatively with the treatment. They can change the way drugs are metabolized, as well as fasting or eating can change that. So it's important that we work together and we don't improvise. If you have someone else that is not part of the team that is advising a patient with cancer, it is much better if they know very well what everybody else is doing.
Nice. So Dr. Rene, so I'm extremely sorry that you had to witness and go through your friend's cancer crisis moment. Are you able to recall any moments with him, any interactions with him that made him feel better? Now the question to you specifically is, what do you think you feel are going to make the patients less anxious?
So I'll answer, there are two questions there. That is the interaction with the neighbor who was he had actually refused pain medication. So he was in a lot of pain. And stoically walking his way towards the end. And we sat, and the journey was all the wonderful things he did in his life.
Okay.
The memories that is part of his life. He was going through that, And he said something where he lived in the United States, he said something very unusual. He said, I've never been to California.
Wow.
Okay, and he's traveled all over America, but never to California. And I didn't ask him why, but he felt that it was a need to tell me that. And he said, Rene, I love what you do. We used to have chats about the technology as it's being developed. But carry on. So there was an encouragement, and he passed away the next day. So that's one side of the story. But the part that I also remember, this is from a caring physician who took care of Parkinson's patients, not necessarily things, who also passed away. But one of the things I noticed was he was extremely funny.
Okay.
Would joke and laugh. And he said, Rene, that is part of how I help my patients. He was naturally funny. And he would make everybody relax and de-stress. And he said, that's part of my job is beyond giving them drugs. It's also nurturing what we all know, that laughter is medicine.
Agreed, completely.
Right. So it was one of his well-known strategies, and his patients loved him to death, okay? And so what I realized is that doctors have many tools that they have at their disposal, only some of which are the standard of practice medication, but it's the relationship they build, the trust they have, and the emotional support they give. It's a very hard job. It's more than what you learn in medical school. It is learned on the job. And they do a heroic job that most of us are not called to do in our different professions, right? So there's an admiration of that. So that's kind of my experience of what should you do when all medications have failed, try to be with your patient and try to be funny and act and bring them to the point where you're laughing together, even though both of you know one of you won't be around a few hours from now or a few days from now.
I think that's some valuable insight that you offer, Dr. Rene. And Dr. Pietro, I think by now we can combinedly agree that for seeing cancer patients in the ER, on the emergency bay area, we need a separate space, correct? We can't keep them with trauma patients and, acute injuries, and they need a separate space.
We need more space altogether. And we need to solve the problem of patient flow throughout acute hospitals, which is penalizing everyone. Cancer patients, patients in pain, frail elderly, confused patients, patients that need privacy and sheltering. There's a very long list of patients that should not spend time in the ER, but they do.
Yeah, and I also would like to personally add on with 10 plus years of experience in surgical practice and having been a part of more than thousands of cancer surgeries and dealing with cancer patients myself, I feel that despite the step-by-step graded exposure of the delivery of the ominous news, I feel what will make them really less anxious is walking them through what is going to happen in the near future, and if the surgeon or the actual caregiver, like the medical oncologist or the surgical oncologist, spend more time with the cancer patient than the primary care point, they will feel less anxious. And most of them are actually comfortable. First of all, we'll have to give them an option whether they want to know more. We can't flood them with the information. If they want to know more, the best aspect would be to walk them through the steps of what is exactly going to happen to them, what the prognosis is, and to be completely honest and be transparent about the entire process. That gives them a lot of courage and confidence in the caregiver. And back to you, Mr. Stephen Wall. So I remember you spoke about supplements, right?
Yeah.
For cancer patients.
Yes.
What kind of supplements do you think can actually alleviate or relieve the anxiety of a cancer patient, or maybe even tone them up, improve their protein and nutrition?
I think there are many supplements you can give during cancer or before cancer also. You're right, you must check the chemotherapy, because some supplements are bad for the chemotherapy. You can give them after the therapy eventually, not during the therapy. But we have much. I begin with curcumin, a supplement, sulforaphane as a supplement, green tea, matcha as a supplement, berberine as a supplement like metformin, or repurposed drugs like phenbendazole, albendazole, ivermectin, disulfiram, metformin.
Okay.
All these things are can be tried to give, but ever with a talk with the oncologist. Yeah, not alone normally.
Can I ask a question on supplements? So it's kind of well known that parsley has one of the most potent anti-tumor agents. Are you aware of that?
But
Parsley, the green parsley, Parsley.
it's not the green tea, no?
No. You can look it up. It's a Japanese group that has, they're available as supplements now because it's natural. And to be honest, I didn't believe it in the beginning, but the actual potent ingredient is sold. And in our cancer models, we have used them. And I can tell you, they are so darn effective. There are a couple of clinical trials, in which I've seen results where they augment the standard therapies, chemotherapy, with this compound whose name I'm blocking on, but it comes from parsley. So one of the most useful ingredients that you could ever eat to keep your tumorigenicity down is eat parsley. And that's where food, it's a natural thing, it's been around for hundreds of years, it's very dominant in Middle Eastern culture, but also in European culture. I would advocate that as a strategy to prevent.
Interesting.
And it's amazing how few people know about parsley.
Yeah.
But it's well published, documented, and I did them in my own lab with a brain cancer model. It was very effective.
Interesting.
Perhaps I knew the German word.
Yeah. So tell all your family and friends that this is, if there's one take-home lesson that you're going to learn of prevention on cancer, eat your parsley. And eat your tabbouleh salad if you're Middle Eastern. I love tabbouleh salad now.
Dr. Pietro, now, since you're in the ER and emergency care physician, one other thing that came to my mind was so many of your cancer care patients would have Rayleigh tube, nasogastric tubes, and tracheostomy tubes, maybe on the PEG, PEG tubes. What would your immediate reaction be when they say, no, please take that off, doctor, I don't want it? How would you deal with that?
With a lot of respect and understanding. And I think very often we need to understand better what's going on in people's minds. One thing that I call a bit the dark side of oncology services, it's a bit of a paradox. I believe whoever receives a diagnosis of cancer, the first thing that your mind thinks is, I'm going to die. But then, when we look after patients that come with advanced metastatic cancer on a second, third, fourth line therapy, with feeding tubes like you have described, with lots of complications, and they are generally approaching the end of their lives. And we ask them, what do you want us to do? Have you thought about how you want to die, where you want to die? How far do you want to go with treatment? How aggressive do you want the treatment to be? Is there something you definitely would never consider? Very often, that conversation hasn't happened. They had multiple encounters with multiple professionals, and all they talked about was the therapy, never a long-term plan, never a plan about their dignity, their quality of life. Maybe it varies depending on the countries, depending on the setup. I'm aware there are hospitals that have developed cancer teams that include, for example, energy healers, nutritionists, health coaches. So they will probably have a better opportunity to talk about these things. But the standard model of care is very medically based on outcomes, on delivering the treatment, measuring the follow-up, dealing with the complications, and move on. It's like a production line.
Okay.
And we miss that opportunity to talk about life and death with the individual.
Yeah.
My memory comes back. The potent compound in parsley is called apigenin. And it's available, I think if you are cancer prone, I would add that to my diet. If you're not, I would prefer the natural form, which is very abundant in parsley, but it's also found in celery.
Oh.
So these are little hints of how Mother Nature actually provides you with things you may not know, but your grandmother did, because parsley wouldn't be in our diet if grandma didn't know that.
Agree, completely. So it's pretty much all about starting difficult conversations with patients having cancer. We have about 8 minutes left. And any questions that the audience have?
Okay. Good afternoon.
Good afternoon. Yeah. Oh my God. I think she's fine. She's getting emotional. So.
My apologies.
Yeah, sorry for that. Yeah.
You don't need to apologize. We're all human.
This is home. I am a breast cancer survivor, so a lot of what you all have been talking about today.
Yeah. First of all, I think she needs a standing ovation. And she's a breast cancer survivor. Yep. I think.
So thank you.
Please go on, madam. Yeah.
Everything that you talked about today was on point. Even about the conversation, because when I was first diagnosed, it was like a wonk, 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 as you mentioned. I heard her, but I wasn't sure. And so my response was, so do you mean I have cancer? And if so, how would I explain this to my mother? That was the first thing I was worried about, was how would I explain it? Because when they said it, it was the medical term, and I wasn't quite sure. So I started off at one hospital, and I ended up going to, at the time it was Cancer Treatment Center of America, which is now City of Hope. And I went to that and stayed with that facility because of the multidisciplinary support. I had a nutritionist, therapist, dietitian, the oncologist, the surgeon. All of those factors and how they took care of me were instrumental in my healing. I had my moment initially of the shock, but soon thereafter, after that initial shock, it was positive thoughts, affirmation. I was grateful. It's weird to explain to other people about being grateful for the journey, but I knew that the battle had to be the positive thinking, which you talked about earlier, the positive thoughts. That truly was. My diagnosis was chemotherapy and radiation until they did the MRI and realized that I had all over one of my breast areas. So then I had to have a mastectomy. I did the genetic counseling testing. That was something that my doctor recommended, as well as my sisters, to make sure that I did not have a BRCA gene, which was very instrumental. I do not, so that was helpful because that would have also made a determination of how I would move forward. So I did not have to do chemo or radiation, but my doctors, suddenly I did have to do the supplements. I did, turmeric, vitamin D. I have very, very low vitamin D. I didn't know that was an indicator. And so I had probably some signs before then, but I didn't know. Fast forward to a month today, my father is now diagnosed with prostate cancer, stage 4A. And I immediately referred him to where I go because I knew the type of care and I knew that was important. The challenge comes in when you have a 77-year-old who, although you have a daughter, I have two sisters that are physicians, and him trying to explain that he doesn't want to do certain types of treatment because, as he understood growing up, my grandmother was an avid gardener. She lived to be 99. So in those days, they did use natural remedies, which I would love to talk about that later. We finally convinced him to do some form of radiation, but the key was the doctors walking him through, pulling up the scans, walking him through the different options. He had a lot of questions. He's not tech savvy. We go on the portal. So it was really important for him to really understand because in his mind, he wants to do anything that's natural. He's a supplemental. He's very natural. He's always our entire life. And so that's been challenging for us as the children and my mother because we want him to get the best. We want him to get the radiation, whatever that we need to do. But in his mind, no, I want to do naturopathic ways. And so now that we've gotten to that point, he wants to still do those natural things because his mind, which I agree, he has to prepare his body. He's 77. He when he got the diagnosis was his birthday. So now he wants to make sure that his body is ready to take on whatever that may be. So the XRT, the injection for 3 months, and then doing the radiation. So my question to you is, I would love to know more about the naturopathic part, because I do want to ease his mind. The parsley, absolutely. We're familiar with the parsley. He has taken out red meat, more veggies and fruits, things of that nature. So I would love to hear more about that. But the conversation, obviously, for me was different than having a conversation with an elder who has gone through times where, like you said, medicine in his time were natural things. So trying to convince us, and him trying to tell us, you have to understand how I was raised. How do you have those conversations with elders who are not really wanting, because all they hear is just chemicals going into my body. And in his mind, he's like, well, I'm really about quality of life over anything else. So how should we have those conversations?
I can tell you one other thing that you would need to add to his diet. It's called a trace element called selenium. Selenium and selenoproteins are very big factors in your immune system that fights cancer. If you become deficient in selenium, you become highly susceptible to infections as well as cancer.
Okay.
And this was not known during COVID. I was shocked that the medical community never talked about the natural things that raised your immunity. Later on, they talked, like during COVID, vitamin D and selenium were the essence of boosting your immunosystems. But we heard all the masking and all the distances and all the rubbish. But not. What really mattered is your metabolic balance or imbalance that made you highly susceptible to infectious disease. It was a big flop across the world. And I hold that, I taught in the medical schools, because doctors learn about 1 hour of nutrition in their entire education. And they don't know how crucial that is to your overall health. Stop there.
So Dr. Pietro, would you
Not
like to?
all doctors are created equal. So I
Agree,
was
agree.
blessed that
I got two doctors sitting right next to me. Incredible.
I was blessed that during
They gotta
my
give me
I
a
would
good
partially
beating, so-
agree with
I
Dr.
agree
Rene
that-
and disagree. Partially agree and disagree. Now to Dr. Pietro.
So
How do
for-
you?
In my education, when I studied biochemistry, my teacher was the head of the School of Nutrition. So I was exposed since a very early age to concepts about nutrition. And then I went to the US and I followed the program in functional medicine of the Institute for Functional Medicine, and learned a lot about nutrition and supplements. So coming to selenium, it's important not to overdo it, because if you take too much, it suppresses the thyroid function. So the equivalent of 3 Brazil nuts per day gives you an amount of selenium that is physiological. If you take more, you can develop hypothyroidism, so you need to be cautious. Like with any supplements, it's important to know how they work, how they interact with each other. And there are more and more nutritionists that specialize in cancer care. I think there is an element that is about prevention. So healthy diet, reducing inflammation in the body, increasing antioxidants, having a healthy weight, activity, good mindset, all of that works in prevention. When you step into treatment, you have already developed cancer, then you need someone that is highly specialized in supporting patients, especially if you're combining it with radiation, with chemotherapy, with immunotherapy. And it's not just because of the interactions. Also, some things can potentiate the effect and they can minimize the side effects. For example, nausea is a very common side effect of many cancer treatments, and it can be managed with certain types of fasting. So my advice would be get in touch with a functional nutritionist or a functional medicine doctor that specializes in cancer care. The limit about the treatment, why is it not widespread? we don't have a lot of large studies of good quality that reach the same gold standard, high numbers and evidence of pharmaceutical compounds, simply because we haven't spent a lot of money studying those. So you have to go with smaller studies and a lot by the experience of the practitioners. Okay. And institutions like IFM are collecting more and more this kind of information and educating a whole new generation of doctors and practitioners.
I agree. That was a very valid question that you had asked. And in fact, at this juncture, I get reminded of this one famous saying from this Tamil language, which I think Dr. Rene also would accept. I think it's unave marundu and marunde unavu. So one vital aspect that we're discussing now is what we would, or how we would deal with patients who have gotten cancer. But the most important aspect is how do we prevent it? And a little bit of all the micronutrients that what Dr. Rene had talked, selenium and other vital minerals, these all address even at the preventive stages. So that was just something that came to my mind, that food is very vital and that does a lot in prevention of cancer. Anything else?
Hi. I wanted actually to ask about the preventive, which is now quite elaborated. Thank you for that. But just a few things, or 2 points actually that I had. My 3 best friends got diagnosed with breast cancer. I lost a friend for pancreas cancer. It runs in my family, be it thyroid or breast cancer. So in my head, I started to get over-worried about my sisters and my mother. What should I do? Especially when, you guys mentioned several times or a couple of times that stage 3 and 4 are too late. Okay, what do I do to reveal it when we're in stage 1 and 2? My friend got leukemia and she discovered that after 2 years, just because the doctor wasn't able to do the right correlation and tell her, oh, watch out, your white cells are too low or too high in your blood. So is there, breast cancer, okay, we know, we go mammogram and we investigate. Is there something that's more holistic?
You also have this genetic testing where, beforehand you can test for BRCA genes, any chromosomal abnormalities that you have, and a lot of genetic testings for specific cancers. And I think my friend, Dr. Rene, he's also a molecular scientist. He knows a lot about.
Yes, I'll tell you how misleading the BRCA test is, okay? And I'll give you an example. We worked in the field of Alzheimer's. They came up with 74 variants, kind of like the BRCA variant, that they said is responsible or correlated with Alzheimer's. The answer is it is over 1,500. Why can't they see it? Because of how they measure this. They collect millions of the most inefficient ways and sequence genes. That tells you nothing about your susceptibility. We do what is called functional profiling. We look at all your genes and how they function. And I'm going to tell you, we can see the BRCA gene dysregulated, but carries no mutation. So you'll be blind to the fact that you are actually susceptible. We're the only ones in the world who can do it, which is why our technology is so vastly superior. We can detect Alzheimer's and all these brain diseases that come in life 50 years before you get it. So I think the world hasn't caught up, which is why we are pushing and pushing and pushing to bring this to the entire world, which is why I'm here in the Middle East trying to bring this, because it'll save lives, because you will know your risk. And here's the better news. There are companion interventions, including specific things that are nutritional, that'll save your life, because you see it shift the balance towards normalcy. It wouldn't necessarily have to be a drug. It'll be in your hands, your nutritionist's hands, in your control to do the right thing so that your life trajectory won't be heading towards waking up one day with a mammary tumor and your only option being radiation, chemo, and mastectomy. That's the kind of science we want.
Dr. Pietro, would you like to add on?
Yes, just briefly. There are also newer tests that are available. So the traditional way to look for the presence of cancer, apart from imaging, was the detection of certain molecules, certain antigens. There are newer tests that are being studied that detect circulating DNA fragments in the blood. For example, the NHS is starting a big trial, has already started a big trial to see if that can be useful for screening purpose to detect cancer, exactly like you said, at a very early stage and improve outcomes. We don't fully know the validity of this test yet. It's been studied, but it is already commercially available, and there are multiple laboratories that already offer that.
Thank you. Just on a positive note, is there an age after which we said we can say, okay, I passed, no further cancer after this age, or no, it never?
I'd just like to add on that. Again, I think I'm going to face some fierce criticism from Dr. Reddy, because he works right at the labs. And in one of the previous panel discussions, as they say, the labs are 3 years ahead of what the clinicians already know. So the thing is,
we are 50 years ahead of what the clinicians know.
yeah,
Not 3 years ahead.
I'll accept that with a humble apology.
Sorry, I'm joking, but we are quite far ahead.
Yeah,
because the technology we bring is a new technology.
Yeah.
And it has much more power of resolution, speed, and precision. And it is going to be the future, whether you like it or not, because it'll save lives and it'll give you options long before the clinical disease appears, at which time you have to do Herculean things in cancer, radiation, chemo, CAR T cell therapy, all these things. And then, all the conversations we're having at end of life, maybe you won't have to have them. We just eliminate those conversations because we save you from all that stuff. That's my goal. Stop it.
As clinicians, we have something called as circulating tumor cells. That is another test. So when we do this CTC testing, we know for sure that whether a person is cancer-free or not after a particular age. So you do that blood test of circulating tumor cells. That's one way to find out. But as Dr. Rene pointed out, we are eons behind, and a lot of research is taking place. Yeah.
All right,
Thank you.
thank you so much. A wonderful panel, and I think the topic you've discussed has definitely brought a lot of confidence and compassion around, because this was a very important topic to discuss how we can get over things. So thank you so much, our moderator and our panelist. Can I please request you to get a picture together?